to this afternoon, I put it together really just because I do get cases now, that are more, I guess you could say they are in the realm of pain management. But these are patients that have gone through the traditional medical system, have been told over and over that you're just going to have to live with it. There's nothing you can do with it. And I'm actually glad to have spoken to Dr. Hassan today. And I saw there was another pain management doctor on the call. And the reason why I'm also excited that he got on to this conference call, because this is also an opportunity to learn. And so all I'm doing basically here is presenting a case. I get a lot of word of mouth referrals, and I tell my patients, we do have therapies. I mean, everything doesn't have to be do this treatment and either has to work or not work. What about if we can improve the condition? What if we can make it better? What if we can make the pain 25% less, 50% less? I mean, if nothing else is working, why not? And this is really a case I think that we could bring up for discussion and realize that, no, I'm not a pain management doctor, but I think this will open up some curiosity and open up what this academy is all about. So I have a 59-year-old white female from a different state, and forgive if I have any spelling errors, or because I did put this together fast. She unfortunately had a carpal tunnel syndrome surgery about 17 years ago, that in which they lacerated the median nerve, and I mean I can't even imagine, and they had to sew it up, do microsurgery to sew it back together, and she has had consistent severe pain for 17 years. The pain that she describes it as pins and needles, and that what she really has is exaggerated pain to normal touch, which is essentially hyperalgesia. Some of the signs and symptoms that she describes is, she could pinch the tip of her finger, and it does not necessarily fill back up with blood the way that she describes it. So she's got poor capillary refill. She's got constant paresthesias, pins and needles, hyperalgesia. Her left hand is atrophied. Okay, decreased tactile perception, difficulty in buttoning up her clothes, or like putting on earrings. If she were to push her finger to try to, when you try to open up like an earring, the part that opens up, just that little nub can trigger severe pain, exaggerated pain, increased pain with cold weather. Some of the things that she doesn't have, and this is why I thought this was interesting, because she didn't have hand edema ever. She never had hyperemia, no elevated blood pressure, tachyarrhythmias, hyperhidrosis, hyperthermia, hypothermia, insomnia, depression, and anxiety. And the reason why I felt that those were important is because this appears to be more involving the peripheral nerve, and possible involvement, obviously, with the autonomic nervous system, but not enough of a syndrome to involve the limbic system. Okay, and as I've been learning about COVID sequela, I've been learning how to delineate symptoms that may be more of limbic system in origin, that of the hypothalamus, versus, say, vagal dampening or peripheral nerve involvement and the symptoms that go along with it. So appears that this is more of a peripheral nerve problem, but this does involve the autonomic nervous system. Next slide, please, Dr. Halasa.
Yeah, sure. You got it?
Okay, so just a basic history. And at first I thought this was unremarkable. She denies pain meds, which I was pleasantly surprised. But she takes Lostrin or Lowestrin for hot flashes. And she's 59 years old, postmenopausal. I believe she takes it either periodically or maybe she takes it consistently, and I apologize, I don't have that information yet. Progesterone at nighttime, and that's really it. And the reason why I think that there's something there that's significant is the fact that the people who typically get the syndromes, you know, and I see this as a complex regional pain syndrome. It seems to be more common with women over the age of 40 who have some sort of severe trauma, nerve trauma, and it involves either the hands or the feet or the arms or the legs. And when I thought about it, I'm thinking, okay, women over the age of 40 with one limb affected, well, what commonality do they all have? Well, they have suboptimal hormones. So that brings into play, you know, what role would, say, bioidentical estrogen play? And so we could talk about this at the end. Allergies, none. Past medical history, carpal tunnel syndrome, really unremarkable history. Straightforward, mother with a cabbage, social history, doesn't smoke or drink. I just threw this picture up here just as nice to have it, just a visual, and to see exactly where that median nerve is, and to remember that innervation is the well, her pain involves the first 4 digits, not the 5th digit, and we know that you know, the median nerve does not involve the 5th digit. So her pain is literally her whole hand and the first 4 digits. My assessment is that this is a complex regional pain syndrome. Now that, you know, anybody who is in pain management, if that does not seem accurate, please let me know your thoughts. The plan, and the thing that I like about this is that, especially with photomodulatory therapy, is that this plan here really is a complementary approach to, this is not the entire plan, but this is an idea to say, wait, okay, so what do we've got going on here? We've got a nerve injury with you know, suboptimal function, you know, possible alteration in the central and peripheral nervous system, increased excitability of nociceptive neurons, which are decreasing pain thresholds. So that tells me a couple of things. One, and having understood redox reactions much better, which is really the root, the basics of nitromedicine, is that she's in a chronic state of, or oxidative stress is playing a crucial role in the excitability of the neuron, okay, theoretically here. And this is also based on the studies that I have been reviewing. Dr. Halas has sent many of them, some of them I found myself through PubMed, and that the red light is at the 660 frequency, has the ability to shift the redux potential from an oxidative state, or at least of the neurons, to a reduced state, such that there may be a decrease in, I would say, neuron-derived inflammatory release of different interleukins and cytokines, and that this might shift it to a reduced state such that it's not as inflamed and may not be as excitable. I threw on there also alpha lipoic acid because my understanding is that this increases the production of glutathione within the nervous tissue, and that's a natural antioxidant. And then, if we can get it calmed down, we'll start off with the red light, then we can consider other options. And I'm sure there's other options that standard of medicine treatments that the pain medicine docs use. And the great thing about this light therapy, and this is another good one, is what I'm seeing is you can have office equipment, that red light office equipment to treat patients who come in. I often treat them before I do some sort of regenerative treatment. And most of these red lights now are completely applicable for home use. So she can have something that she can do on a regular basis to calm down the excitability and potentially stimulate the regeneration of the injured area of the nerve, reduce scar tissue around the nerve from the injury that's probably still there from the original injury, as that's what the body does. Is the body gets injured, produces scar tissue, and then it stops regenerating. And if we can re-stimulate that regenerative process, potentially we can get some healing of nervous tissue. Also, PRP lysate as a option, similar to exosomes. PRP lysate is a way to create platelet-rich plasma that is not only anti-inflammatory, because the idea is to stimulate it with a light, the right light frequency, to shift it to an anti-inflammatory morphology, and then sonicate it, causing the release of the platelets, thus enabling us to concentrate, almost like a growth factor, anti-inflammatory growth factor, liposome, exosome soup at much higher concentrations than we can make with PRP. Not to mention, if we were to make PRP at extremely high concentrations, I can tell you from experience that concoction is extremely inflammatory. To inject something that's 10, 20 times the physiological level of platelets, that, in my experience, can cause extreme swelling, inflammation. And not that that's necessarily a bad thing in general, because when we regenerate, when we attempt to help the body to regenerate, we are in essence re-stimulating the healing mechanism, the cascade of events that causes the body to heal. But in somebody with a complex regional pain syndrome, and this is speculation, I would say that that seems like that would be risky, because that's already hyper-excitable to begin with, and the last thing I want to do is make that hyper-excitability worse. So therefore, the PRP lysate is a great way to consider in this situation, and I'm hoping to get some feedback, a way to, again, you've got the light, but there's always, in my experience in regenerative medicine, you always want to combine different regenerative approaches. So whether it's exosomes or PRP lysate, which is basically platelet exosomes, to have a light frequency that is doing one thing, or at least activating the whole cascade of events. And then the PRP lysate is like the fertilizer to enhance the breaking down of scar tissue and recruitment of other healing cells involved with the healing mechanism, and helping to restart and jumpstart the healing cascade and regeneration of the damaged nerve tissue. What the goal is to just improve her quality of life. That's it. We're just giving her a chance to improve. And instead of telling her, no, there's nothing you can do, like she's been told, you know, we're not following anybody else's protocols. We're just following evidence-based studies and experience to show that these treatments help. And that's the main thing. Anything that helps her, and she said this, she will be very happy. And so I'm happy to hear any feedback. Thank you.
Hey, Dr. Joseph.
Yes.
This is Bill Cole. How you doing?
Good.
If I really like where you're going with this. I think that you have a lot of the core and the basis of it. If I may throw some things in about diagnosis, over
Yes.
the damn near 20 years I've been figuring things out like that. When you have a CRPS, it's very specific, as opposed to a carpal tunnel syndrome. There is a variety of ways to differentiate them. One of them is the simple physical examination. You use the large paper clip that you undo, and you just go down the arm until you find the pattern of the pain. And it always gives a pattern of a nerve. So unless there's an underlying, everything has a pattern though. Every muscle, every nerve, even blood vessels, when they're dysfunctional, have a pattern. So, and ligaments and tendons. So you follow the pattern and you see which pattern it gives you. If you wanted to be more precise with it, again, you know, for carpal tunnel, you do the Tinel's, the Phelan's sign. And if you're fairly firm with that, you can differentiate that into the different nerves. Also, if you want to know delineated specifically, you get a nerve conduction study, and that's possible too. And that could be very helpful if you want to actually diagnose what is the CRPS, and which used to be reflex sympathetic dystrophy, and can be complex regional pain syndrome. So there's other things there too. So the next point is there a dysfunction of the muscle, nerve, blood vessel, which is dysfunctional? And you can actually tell by the physical exam on that. Yeah, you're exactly right about the PRP. When you super concentrate it, it has quite inflammatory properties. But let's think about it this way. The way I always explain it is if you go to get a house, it's a great deal, but it's on the beach and the hurricane already hit it. Well, it's going to need some work. But what do you have to do first? You have to have the blueprint. That's your DNA. You already have that. You have to then be able to take out the things that are broken. If it's the screens, the windows, the garage doors bent to hell, those got to be removed. So don't forget the blasts and the osteoclasts have to do their function to take out bone spurs, any type of fibrotic tissue, torn tissue, anything that's not supposed to be there. Your body already knows because it has the DNA. It has the blueprint. So what I've found to be tremendous is it removes those materials and tissue that aren't supposed to be there. And then it will rebuild, and it continues to rebuild. And with the platelet lysate, that will do that even more so, probably without as much of the inflammation, and utilizing the light after you utilize the platelet lysate. So if you look at your own wrist for a second, look at your wrist and then put your thumb on the ulnar portion, right where the hook of hamate is. So if you look at your hand and you put it right on the third crease at the hook of hamate, you'll feel that bone. And you can actually feel that's exactly the site that you go in with an injection at a parallel to the fingers. You go parallel to the fingers, straight ahead. Don't lean toward the fifth digit because you'll hit that little hook of the radial nerve. So you go straight into that, and you can put an anti-inflammatory or numbing agent, first. If you were going to put it in the actual wrist at the median nerve without at the carpal tunnel, without hitting the median nerve. So that's the way you actually find it. You go right next to it, and you have to hug that hook of hamate. When you inject, use ultrasound, because there's a big blood vessel there. You don't want to hit it. And then the nerve. So I like everything you're doing. You can specifically delineate between the different neurologic disorders with a little bit of physical examination, possibly like I said, a nerve conduction study if you want to be very specific. And then you look at some of the other features of CRPS, the hair loss, the hypersensitivity, sometimes almost like a Raynaud's where it's super sensitive to hot or cold. And then you can tell from there. And then you want to do desensitization techniques. I think the laser is a great idea for that.
Mhm.
Is this diagnosed now? You're saying it's not anymore carpal tunnel. It is complex with complex regional pain syndrome. And you have the signs of and the symptoms of complex region. You have hyperalgesia. You have also all over the hands is hyperalgesic. So the patient cannot touch the hands. When you touch it, they get pain. Not in the distribution of the median nerve. Also, the color of the skin. Did you see any change in the color of the skin? Blue, red,
Well,
swelling? That's all there, right? So this is complex regional pain syndrome, so above the carpal tunnel. Is that right, Dr. Joseph?
Yeah, and keep in mind, this is a patient that's out of state, so I've not had a chance to actually physically touch and see her hand, but based on the questions directed to find out exactly, color change. She didn't have color change. No edema, but the hyperalgesia for sure, and that is the main issue. Along with, she does have motor. Obviously, she's got weakness and decreased range of motion, and also atrophy of her hand as well.
Yeah. Okay.
Yeah. So that may go with complex. If you have hyperalgesia, it does not follow the lines of median nerve outside the median. Then if you can say this is complex regional pain syndrome. And when you manage complex pain syndrome, it's completely different from carpal tunnel.
Yeah.
Those patients, they cannot tolerate any injection for now. If you inject them, you may aggravate the whole pain. This is also, complex regional pain syndrome is not a peripheral pain source. It is centralized pain. So they have neuroplastic change in the brain that is connected to the sympathetic nerve. And that sympathetic nerve is causing release of norepinephrine, stimulated NOx enzyme, which generate free radicals and causing inflammations, and also causing this vascular instability, vasomotor instability. So you can see that they become a little bit hyperemia and bluish and change in the color. But I don't think she's in the stage of the change in the color or coldness, feeling coldness, and of the temperature and all that stuff. So we need to make sure that but still, I think hyperalgesia itself, that does not follow distribution of median nerve, that's all over her hand, it indicates that she is getting into the complex regional pain syndrome. I would not inject needles in those patients, because when you do that, you trigger more. And if you say, no, I want to inject it to other side and give them IV, I did it with one patient. And what happened, the pain can transfer from one arm to another. So when I go with this patient with complex regional pain syndrome, the real ones, they will go through photomedicine first, sessions, until they start able to touch their hands. And that's where the inflammation a little bit got subsided then I can go ahead with topical cream using DMSO, alpha lipoic acid combined. Dr. Mike Beamer can compound it, put nitroglycerin there, put some nifedipine there, and you can get that controlled with this topical cream. You can mix the platelet lysates with a topical cream. That's fine because they're nano-sized. Possibly those growth factors will help. And with DMSO, they will be pushed through the skin. I think that's possible. But I will not do injection for those people until I manage the complex regional pain syndrome. And if it turn into carpal tunnel only, then you can go ahead and say I'm injecting vitamin B12. I inject, like Dr. Cole is saying, inject platelet lysate, vitamin B12. Yeah, then you can go. But for complex regional pain syndromes, no needles until the pain is subsided and you manage it. Then whatever left, you can go ahead and proceed with that. This is my
Yeah.
best advice for complex regional pain syndrome.
Yeah, Dr. Halassa, I agree. What I was differentiating is on the physical exam. If it was only the carpal tunnel versus the CRPS, it's easy to differentiate, and it's a different diagnosis and treatment plan, of course. And the desensitization is highly important. You can also follow the nerve up to the point where it stops being sensitive. And there's usually a precipitating event. So when you ask, there's almost 99% of the time, there's always a precipitating event where they had fallen or something else, or it makes it the weakest link, therefore susceptible to the CRPS too. So you always ask, and it'll reveal some good information for you too.
Let me add something else. Complex regional pain syndrome is a combination of central pain. So you have neuroplastic changes in the brain, in addition to the inflammation and sympathetic overactivity in the peripheral. And
Yeah,
yes,
but that's long term. That's long term. That's not the initial.
Yeah,
So
I'm just saying. No, yeah,
that's long
well,
term.
I don't know about
The
this
initial
patient.
symptoms. The
Right.
initial symptoms are the precipitating event. Then
Right.
you stop using it, and you condition your brain to not use it. Therefore, your brain changes in the way it treats that limb, and that's what causes a lot of the hyperalgesia and the other problems, because you purposefully don't use it. So there usually is precipitating events.
Well, complex regional pain syndrome, part of it is sympathetic overactivities, and that leads to inflammation and the swelling. It's a neurogenic coming from the sympathetic that's connected to your pain fibers through this neuroplastic changes. And I have a very good presentation for it. So for this patient, I will, regardless, if I see hyperalgesia, I will still work out on it as if there's some central pain and some neuroplastic changes. And I would just start giving her intranasal CBD, intranasal platelet lysates, B12, just to make sure, or just to help to possibly restore the neuroplasticity of the brain and manage the central part of the pain. In addition to targeting the peripheral, I also will target the light in her neck to the sympathetic ganglion, put some red light and infrared into her sympathetic ganglion. We know that the way that we treat complex regional pain syndrome, we block the sympathetic ganglions. And that's part of the process, because sympathetic overactivities, it's the reason why we have this inflammation, vasomotor instability, and activation of NOx enzyme that leads to the inflammation part. And I will also radiate the neck, because neuroplastic changes, it's happening in both at the spinal cord level and at the brain level. So intranasal light therapy and shining the neck with red light and infrared, and then also the peripheral nociceptive part of it. Doing that, with time, you'll be able to manage, and if they're taking narcotics, you'll be able to wean them. Narcotic, actually,
No.
it does aggravate the complex regional pain syndrome. So yes, you can get short-term relief, but the narcotic itself can induce oxidative stress, can complicate the complex regional pain syndrome, and push the neuroplasticity more worseness. It will worsen the whole complex regional pain syndrome, and then you need more narcotics. So really, narcotic, it will push the disease into the edge.
Yeah. You don't want to use narcotics. Narcotics do not work for nerve pain. This comes from somebody who has 2 certified pain management clinics. And I see this all the time, day in, day out. Narcotics do not work for nerve pain. They never have. They never will. So don't use them. I was going to ask you about glutathione. What do you think about that?
Yeah, glutathione, anything that thiols, that buffer the redox. You can do topical gabapentin. That's fine. I'm not the savvy integrative doctor. I will go ahead, use some mainstream medicine. And Dr. Mike Beamer can put a very strong formula, and he will put high dose of DSMO, because DSMO does have very good effect in neuroinflammation. So he can put a very good cream for you. After she go through at least 2-week sessions of light therapy, then she can apply. Those complex region pain syndrome, they can touch themselves, but they cannot allow anybody else to touch them. So that's one of the things. So she can apply the cream by herself, but I just go ahead with 2 weeks of light therapy only, not just her arm, but also her neck and the sympathetic ganglion, and then go with the topical cream that Mike Beamer will compound it. And that include everything there. I mean, it will include some GABA, some nitroglycerin. Nitroglycerin is very effective. I did a lot of nitroglycerin-based topical cream. We develop even nitro bases, something that Dr. Horatio will be interested in Australia. We call this nitro medicine formulation, Dr. Mike Beamer. Are you there, Dr. Mike Beamer? Dr. Mike Beamer, are you there?
Hey, I'm here. Hi, Dr. Wallace. How are
Yeah,
you?
so this is we go into your topical cream. So I want you to talk about it more and what you're doing with those conditions.
Well, yeah, okay. Yeah, that's interesting. In this particular patient, I do probably see a role for that. And we work with some hand surgeons and orthopedic experts, and we've had pretty good luck with this type of treatment. When you look at topical pain supplementation, we use liposomal delivery systems or microsomal delivery systems in the 40 to 80 nanometer.
You got disconnected there.
Load those with the yeah, and then you're looking at your normal kind of topical pain management things that you have the option to use. Which are things of the sort of baclofen, nifedipine. Nifedipine might be interesting here. You have your NSAIDs, you have your gabapentin, amitriptyline, ketamine, things of this nature. So these are kind of the host of pain management options that you have topically. One of the things, though, that we've implemented more recently are these nitromedicine vehicles that have high percentages of curcumin, glutathione, alpha lipoic acid. And this might be a nice thing in this particular area, is literally some topical nutritional supplementation to the local area, which can be done. So yeah, you can combine the pharmaceutical drug potentially in a lower dose with some redox balancing fuel and nutritionals, and that's all something that can be done affordably for people nowadays. So yep.
And also you can add palmitoyl ethanolamide as well. That helps a lot according to the Europeans version of pain management. Palmitoyl ethanolamide, which is extraction from.
And we have PEA. Yeah, PEA is a cannabinoid agonist, and it also is a PPAR inhibitor. And I believe, if I'm correct, curcumin is PPAR gamma, and I think the PEA, palmitoyl ethanolamide, is a PPAR alpha suppressor. So it's suppressing that, which ends up at the end of the day suppressing NF-kappa B, which is a helpful thing in this case.
And especially DSMO with high dose, proven to be it works very well with complex regional pain syndrome. So Dr. Mike Beamer will create that cream for you, along with your light therapy, until everything is subsided and it's not anymore complex regional pain syndrome. You may end up still you have this carpal tunnel. Then you need to manage it with the carpal tunnel measurements, and possibly some release if it's possible. There is technique to release carpal tunnel in the office using certain needle that has a curve, which you can cut those fibrous tissues. There's a procedure for that. You can do it.
Oh, no. You don't want to cut them. It'll cause more fibrosis.
Can I intervene with something?
Please.
Okay, so I think from what Dr. Joseph's presentation, I agree it's a complex regional pain syndrome, and I think he mentioned it's type 2. So we have to differentiate between type 2 and type 1, which type 1 is what they referred to in the past used to be an RSD. But a type 2 is what the causalgia, and the main difference in how do we know is one is with a nerve damage and the other without. So when you talk about complex regional pain syndrome type 2 is with the nerve damage that which the patient sounds like she has an atrophy, dysfunction, and paresthesia and sensory loss. So those are much harder to treat than type 1, where we all, I think, agree on the same management is with a sympathetic blockade, local physical therapy, and mobilization. And usually the damage is at the nerve fibers. You don't have like major nerve damage. But in her case, it sounds like it's a much harder to treat. And I agree with Dr. Hallis, is the least invasive.
Excuse me, is somebody's making some noise and it's cutting out Dr. Assam's, what he's trying to say?
No, I think he's moving. Go ahead, Dr. Assam.
Okay, so what I said is the less invasive with those patients, the better, because basically anything that can aggravate the nerve and especially so you really have to be careful what you inject locally. I agree. I think that you want to know definitely maybe by doing a nerve conduction study, and this will tell you either there's a nerve damage or not. I don't think it will be conclusive. It will tell you specifically what nerve is damaged if she has significant weakness and muscle wasting. So once you have a diagnosis that is actually a specific nerve that is actually damaged, then the therapies that all the therapies alternative are done. As far as locally, sometimes if there's a nerve damage, and sometimes there's actually scarring. So they usually like the nerve, if they're damaged, but they're actually caught in the scar, and that's when they're not insulated, but they're scarred. So so you have a constant firing, and there's not enough insulation. So the release of the scar is something that can be tried, and that can be just done by local injection, simply either with a saline or a local anesthetics. And what that does, basically, you're doing like a hydrodissection. So like by injecting fluids, it can separate the tissues and can free up the nerve. So if there is any scar around the nerve, and I've tried, I had a very good luck, actually, not specifically in the hand. And the hand is very sensitive for me to kind of like play with, because all the kind of like, it's a functions and it's a hand. But I had a lot of good luck with either a hernia scar, hysterectomy scars, abdominal scars, where the one of the iliac nerves, iliohypogastric or iliofemoral nerves, are caught in the scar, and obviously the first thing I want to know is establish really good rapport with the patients, because you really want to have the trust of the patient, and that they're really seeking help with the pain. They're not seeking because they have to give you a good feedback after the injection. But I had a several time a scar release in the abdomen just by injecting a small volume around the nerve and around the scar, and that can help really cause a long-term relief. But all these other therapies sound interesting as far as the phototherapy and photomodulation. Those seems to be a nice non-invasive. That would be one thing that I would start with when treating the pain in the hand in such complexity.
Yeah, I couldn't agree more about the scarring, because you have to be careful. Many people that have had a carpal tunnel release, the carpal tunnel comes back because they're using a knife. When you use a knife, it causes more scar tissue. Whereas some of them, when they're done with a laser, it cauterizes automatically and it does not create more scar tissue. Do you ever do the dissection with a mix of lidocaine so that it actually numbs the nerve as you dissect?
Yeah, so I do lidocaine, and also, and on a second time or third time, once I trust the patient that actually they interact well with me, I even put steroids, because the steroids is anti-inflammatory, especially like an African American, they have tendency to cause a lot of scar and
Keloids.
keloids as well. Exactly. So with those, it's like you break the scar, and then 3-4 weeks later, it kind of forms another scar.
Yeah.
So steroids can suppress the collagen, and then especially like, as you know, like the collagen scar remodulate itself over like 18 months to 2 years. The scar is not stable. It's kind of constantly building collagen and breakdown. So whenever there's a scar around a nerve, and a hyperalgesia, and then a scar therapy would be indicated. I usually always try to put some steroids as an anti-inflammatory, so when the scar reform, it won't cause it kind of like becomes more smoother healing, and not recurrent. And that usually, when the pain comes back, it doesn't come back as bad. It would come back less. And then when you hit it 2-3 times over 6 months period, then eventually that central sensitization, you can overcome that central sensitization. One case really stuck in my brain was a lady after a C-section scar. She was like so depressed, so in a bad mood, and almost crying when she came to me. And I only did, I think I only did like 2 treatments for her, 2 injections, 2 months apart. And then her pain was down to less than 50%. And she was able to move on with her life, taking care of her kids and family. So I think scar therapy is one of the things that can be done with minimal disruption, but we just have to be very careful when there is a big major nerve damage like this hand case.
I have a question, Dr. Assam, and for anybody else. Any thoughts on ketamine therapy, IV ketamine, sublingual ketamine? Any ideas?
Yeah, ketamine is also is a very good medication. So I mean, I had a very good experience with acute pain that we did ketamine. It helps when somebody come in uh, post-surgical and they have acute pain, and then it minimizes the amount of opioids dramatically. So we did ketamine infusion for 24 hours or 48 hours with those patients to minimize their opioids. And then you start titrating it down. On outpatient chronic pain, basically, back then when I was practicing was like the oral ketamine, but that has to be compounded and it's not as effective. We did some infusion ketamine as an outpatient with variable results. So basically, one good indication is when somebody has a bilateral central complex regional pain syndrome. Basically, when you have like this complex regional pain syndrome is out of control, then that would be, and when you have like a central component, that would be a good indication for ketamine. Ketamine been done now for depression, so if there's an element of depression, that also helps overall. But yeah, there is all kind of different. The nasal, intranasal is relatively new. I haven't had a chance to really use it on a good number of patients for chronic pain.
If I may ask, what type of dosage do you recommend for your ketamine work?
So I think the ketamine, it's probably
100 milligrams per
100
mil.
milligrams. Yeah, 100 milligrams. It depends. I was trying to remember how fast you can run it, because like you can, when we did like back then it was like over an hour, but now they're actually using it over 20 minutes. So I think it's a smaller dose even, because I think 100 milligrams over 20 minutes is pretty hefty dose. But for depression now, with depression is much smaller dose. I think it's 20, 30 milligrams over 20 minutes.
Yeah. Only twice a week, I think, and then it has some kind of decreasing protocol with it, you know, like over time. So yeah, it's for acute, but it'll probably be end up being studied a lot more. But yeah, thank you for that.
Yeah, yeah. Thank you. I don't know if
Thank you.
anybody has an experience with a nasal ketamine in this group.
I've sold it before, you know, for migraine headaches or people doing weird things, but I don't think it's really being used properly. You know, topically, it's been used a lot, obviously, for that. But yeah, what you're talking about is intravenous therapy should be.
I had a question. When you use PRP, you do cause some inflammation. When you are using platelet lysate, do you see that type of inflammation? And also, if you do, this is something that you got to be very careful here because it's extremely, it's not like a knee joint. You're dealing with, like you said, scarring. There is loss of Schwann cells. There is all kind of pathologies going around. So does anybody, the question is basically, does platelet lysate has any inflammatory action like PRP does? And if it does, all you have to do, you have to balance the pH with sodium bicarbonate when it comes to PRP. So I wonder if that would apply here with
Yes,
platelet lysate.
exactly the same. I think you do maybe the volume of 1 to 3. Every 3 volume, you do 1 volume of sodium bicarb. Most of the pain is because of the acidity of the platelets. But we actually go through a process of buffering. You say take the blood, and then you shine the blue and red light on the blood, and that helps to buffer the redox. There's a mechanism through nitric oxide itself. It releases nitric oxide from hemoglobinins, and the nitric oxide react with free radicals, become peroxynitrates, and then the red blood cells, they reduce the peroxynitrate to nitric oxide 1. So generally what you're doing, you're buffering and shifting the redox into reduction by exposing the blood with infrared and red. So this is called photoactivated blood, or people, they're doing it with the platelets. I like to do it with the blood first to benefit from the release of nitric oxide from the red blood cells. And then you do centrifugations, and you get red from the red blood cells. And then you do the second centrifugation to concentrate the platelets and the white blood cells. And then you take them to the sonic agents and you break them, you release the nanovesicles. And then you take there's a nanofilter, make sure you get only the size less than 200 0.2 micron, which is 200 nanometer. And you get all those platelet vesicles or exosomes from those syringe by using those filter. And then yes, before you inject it, you add sodium bicarb to the whole mix, 3 to 1, and you buffer the redox. I think you will get less pain. Of course, you want to do lidocaine before to numb the area, and then you inject your platelets. I think it will become painless, especially with adding sodium bicarb. I think that's a good idea. And I think the pain of the platelets is because of the acidity with the manipulations of the platelets. The blood in general, the platelets components will lose the pH and become acidic. And because all this release of those chemical and enzymes and the lysosomes from the white blood cells, all of that's very acidic. So with sodium bicarb taking care of that acidity, you get now it's very important to know, according to the recent publications, platelet lysates or platelet derived exosomes are more effective than the platelets. We explain why, because when we culture those stem cells in vitro, we don't use PRP, we use platelet lysates. Why? Because the stem cells cannot eat the platelets, but they can eat the exosomes derived from the platelet through endocytosis. So you don't get much of the growth effect going to those stem cells if you don't break them down to platelet lysates. That's why we grow the stem cells with platelet lysates versus platelets. Same concept in your joint. Your joint is a culture of cells, of synovial cells, endogenous stem cells, cartilage cells, and also white blood cells. And if you inject the platelets, who's going to take them? Macrophages were going to take them mostly, and yes, you would have some immunomodulations, but you don't get much going to your synovial cells and your cartilage. That's the reason breaking it down releasing those exosomes. Those exosomes will diffuse and will be nourishing or causing the trophic effect of all the cells there, not just the macrophages. So that's the reason I prefer doing platelet lysates as a nanomedicine. That's nanomedicine versus putting bulk of platelets in the joints, or bulk of fat stem cells into the joints, or bulk of bone marrow stem cells. Even fat stem cells, break it down into their exosome-derived fat stem cells. Or you have bone marrow stem cells, break them down, because you're not doing any replacement effect. You're not really, there's not much a significant replacement effect injecting those stem cells. They're eventually going to die, taken by the macrophages. But you're going to have trophic effect. And trophic effect with exosomes is better derived from bone marrow, exosome derived from fat stem cells, or the exosome derived from mesenchymal stem cells. And you, Dr. Fashan, you experience the difference between the amniotic cells, amniotic stem cells, versus the exosome derived from amniotic stem cells. I think the results from exosome is better than injecting the amniotic stem cells. That's my area. But because of the regulatories is hammering against those stem cells things, I want to have my members to focus on platelet-derived exosomes. And
another recommendation that I would do to Dr. Joseph when you are injecting this patient is using a 30 or 31 gauge needle. And if the patient is comfortable, possibly doing some needling around the scar. Now that's going to be like, you have to be somewhat careful, because there is a neurovasculature there that again, you got to do it. You got to see how comfortable is the patient when you're doing that, as you are doing it. A little bit of needling to break down some of those scars, to stimulate regeneration, using a very tiny needle here, like 31 gauge or 31 gauge rather than using a 30 gauge would be I think helpful to your patient.
well, the other option is putting, that's what we're doing. People have fiber optics. There is fiber optic laser that you can put in the joint. So we inject those exosomes, derived platelets or stem cells, and then in the same needle, we catheter the fiber optics, and we shine the laser inside. That laser does cause stimulation of the stem cells, and it does help to buffer the redox, and it helps to kick in the stem cells to proliferate and differentiate. Some remodeling that the microneedling can do. But I think, yes, microneedling, you want to do some scarring in those area of the lesions just to get the exosome moving to that direction. I think it's not a bad idea. But using fiber optic laser is an alternative approach. If you don't want to do any kind of manipulations with your needling, you can also use fiber optic laser, so you see the whole joint shine with red light. And that's a good thing for another reason. The other reason you do this, especially if you add little methylene blue, just 1 milligram, 2 milligram of methylene blue, and in the joint. And you can also secure there will be no infection in the joints. Because one of the complications, which is very rare, it happened that patients end up with infection. But this will prevent the infection, gives you more peace of mind when you use the laser. You know, when you use the fiber optics laser and we're doing it IV, and then you take it out, we no bruising and no scarring, nothing after using the IV laser. And versus when you do all this needling, you see those patients as being poked and they have bruises, right? But we find out from our experience when we did all IV lasers, there will be no blockage of the veins that's happening when you do the needle things. So the laser does have a very effective healing effect, even by absorbing IV lasers and nothing left of bruising or scarring or blocking those veins.
Yeah. Don't forget to desensitize the area before you do the needling. Whatever medium you want to use to do that, tremendously important if they actually have CRPS or causalgia. I was going to ask you, Dr. Alassa, do you find with the platelet lysate, if you were to put that within a joint space that is definitively moderate to severe arthritic, or torn tissue or has basically bone spurs torn up, degenerative. Does the platelet lysate physically, I mean, via imaging, reduce the amount of arthritic joint conditions, which is the bone spurs, scar tissue, torn tissue, or does it remodel?
I believe if you combine it with laser, and you have the fiber optic laser with platelet lysates, because we find that their effect is better than the PRP in all aspects.
Yeah, but do you have any imaging that proves it?
I will share with you some imaging that's been published, but according to the publications and the studies, platelet lysates is way better than PRP.
Well,
And again,
I'll show
I'm
you what I
not
have
talking about
eventually.
building cartilage. We're not building cartilage in all aspects. We are just increasing the synovial cells, production of synovial fluid, so we can use the lubrications. We're slowing the degeneration of the cartilage, but there is no, from all the stem cells therapy that you're doing, and any doctor claims that he's building cartilage, significant cartilage, especially above the age of 50, and you have 50% of the cartilage being damaged. And any doctor say, I am replacing cartilage, he's wrong. Maybe
Okay, well,
young kids,
I'll
yes.
show you what
Right.
I've done eventually, and then you can see it for yourself, because it actually does rebuild whatever tissue you're putting it at. It's all based on how well you heal to begin with. That
Right.
is the baseline. Whatever your status is now, if you can increase that 10 to 15 times the normal healing power, put it right back precision at that joint or torn tissue or ligament, it will do tremendous things to decrease their actual pain. So yes, there is evidence that that does work, no matter what
Yes.
medium you use.
I agree with you. Pain because of the lubrication from the synovial fluid. You are slowing the degeneration of the cartilage. You're pushing the surgery. Instead of having the surgery of 2 years, it goes 5 years, 10 years. But I don't want people in this field to claim that they're building cartilage for somebody who's above 50 years old, who's 50% of his cartilage being messed up. And then when he does the surgery after 5 to 10 years, he will say,
Yeah.
well, I paid that amount of money to
Okay.
that doctor, and he building my cartilage. Why I'm doing the surgery?
Okay.
So that's my point. Okay.
Someday I'll show you my studies, and it does work, but I'm not ready to share all that yet. But they do work, and I know it works because it works on me.
They just gotta
And I-
them, and they're doing regenerative medicine. They're gonna get older. You know, as long as you explain that to them, it's not gonna last forever. You know, it's a very good treatment. Yes, it does. I agree with Dr. Cole. There's studies on this that you are regenerating the cartilage. There is MRI differences, not just X-ray differences. So there's good objective data that biologics do help. I think platelet lysate would help too. I mean, they haven't done studies on that yet as far as cartilage goes, but any kind of growth factor that you could use and then combine that with a good home physical therapy for the patient, maybe put them on some sleeves or some small braces, and then you would see definitely improvement in function, and the knee actually feels stronger. The patient will tell you the knee feels stronger, and certainly the strength is not coming just from getting rid of it's not just getting rid of the pain, but if you're getting strength, that means you are getting brand new cells that have mitochondria in them that are, you producing energy and more stronger, more forceful kicks that the patient does.
Well, one of the things is, if you're going to do a treatment, that's a treatment. But if you're regenerating, by definition, you are regenerating and you are literally rebuilding. So are you treating or are you rebuilding? And there's a big differentiation between them.
This is in a safe side, just in a safe side. Okay. All Dr. Farshan is saying is right. Increasing the lubrication, increasing the synovial cells, proliferation, differentiation, all that stuff, which is very good. Lubrication. If you have the lubrication, you don't have any more pain, right? You're adding more, so you intrinsically slowing the degeneration of the cartilage. That's a good effect. Strengthening the structures surrounding the joints, the ligaments, all that. That's part of the whole thing. But the claim of this will prevent you from having knee surgery after 10 years.
No, nobody can
That
claim
is something I don't want to have the doctors in my network.
Nobody should say that.
Right. So that's my concern.
Right. Nobody should say that.
Right.
I have a practical question. It's Dr. Joseph here. How long should we do the red light, do you think, for this patient in particular, and how far away should the light be with the device that I'm using? How far away from the actual wrist? Should it be far away? Should the light be right up next to the skin?
You want it
Right
to
next to
irradiate
it.
the tissue that you want to treat.
What's
He
that?
said
Sorry?
the wrist for the CRPS.
Yeah.
As long as she's comfortable, she's not. If there's no heat that she's heating, you don't want to have any heating effect where it's causing pain. As long as she's comfortable, you don't want to touch it because touching can cause problems. And the probe itself, it's hot. You cannot really put it. This is very powerful. This is around 15 watt of light. This is very powerful light. All right.
Well, how far away,
This
Dr.
position
Harlan?
is good. This what you're doing. I think the distance is good. But when she feels hot, she has to push it away. So this is something has to do with the comfort of the patient.
Is it physically an inch, 2 inches, and then he's asking how long? So the physical, how far away?
20 minutes. 20 minutes. It's good enough for those patients, as long as there's no heat where painful heat. 20 minutes is good, and do it twice a week. I think it's going to be very effective. If she's doing at home, it's not in the clinic. She can do it on daily basis, 20 minutes every day.
Yeah, but an inch away, 6 inches away.
This is good distance. 1 to 2 inches. As long as she's comfortable, she's not feeling the heat.
2
I
inches.
think that's good.
Okay. Right.
Okay, yeah, and it's interesting you say that because although she said cold weather activates the pain, I said, well, what about warm? She said, well, warm is fine, but if it's too warm, then that also activates her,
That's why she has to feel comfortable.
Analgesia.
So it's a personalized thing. She has to be comfortable. If she feel pain, she has to push it away, or she will lose this time. So it depends. But comfortable of the complex pain, it's very important. Any pain you introduce to the patient makes things worse. It makes the whole sympathetic activity more inflammation and more pain.
Okay, and then what were the landmarks again? Using a 30 gauge needle to inject, and Dr. Cole, you had mentioned the landmarks to, very specifically where to inject, and of course, if anybody else has any ideas, I would probably be very conservative.
Yeah, I agree. Dr. Joseph, it depends on the actual etiology. I was referring to a carpal tunnel by itself for the just on the inside of the hook of the hamate, pointing toward the fourth digit in a parallel fashion, but that's for carpal tunnel strictly with a very thin needle and knowing the anatomy so you're within the carpal tunnel space. However, and you can look that in any of the books, you just want to make sure you hug that hook of hamate, because if you don't, you will get the vein there. So using ultrasound guidance is great. However, if you're using just something simple like a paper clip to follow the pain all the way down to the point where it stops, you'll know approximately where the nerve starts to have a dysfunction. And following the different patterns, you can usually see which nerve is the one that has the etiology. You might want to consider starting to do some therapies right at that site, whether it's a desensitization or some of the DSMO, some of the other things that they stated, the laser, the light, the platelet lysate. But that may be the area where there's a impingement on the nerve, scar tissue, any type of pressure whatsoever, or dysfunction at that nerve site, sometimes you can isolate it, just follow the nerve back to the point where it stops being abnormal. And that sometimes can help.
No,
Okay.
not this case,
And what about, and
not this case,
Go ahead.
doctor. For this case, she's still, if she's diagnosed with complex regional pain syndrome, once you manage it and she doesn't have any more hyperzesia and she can, no problem touching it, it's just more of atrophy and numbness, then that's, you cleared her from complex regional pain syndrome, then it's possible you want to move forward to treat her as carpal tunnel. But this patient's
Well, that's only if it's
specifically,
carpal tunnel. There could be other
right.
diagnoses.
And
There could
another
be
thing is
multiple
that
others.
make sure you shine the light in her neck for this patient's the sympathetic ganglion where they inject the steroids to numb those sympathetic. Yeah, and this light that you have, it's both. It's infrared and red light, so it goes deep.
okay. And, the other thing ideas that I've been working on is the idea of, okay, I'm an example of a family practitioner / internal medicine doc, cosmetic medicine doc. There's lots of physicians that are not necessarily pain management, but they are coming from different fields and interested in treating patients. Like me, the more patients I treat, the more complex patients I get. But I've also found that sometimes there are simple ways to treat them at my level, maybe not as sophisticated as some of the treatments that we went over today. But my understanding is that exosomes in general, whether they're coming from Dr. Farshin, or that right now we're talking about PRP lysate specifically, those are exosomes. They are so small that if you get them even close to the area of concern, they are small enough to get to the area, or at least to permeate. Exactly, that's a great word, permeate the area. So there's still a benefit. Again, maybe not as sophisticated as say a pain management specialist or Dr. Cole and your techniques, but something that the average open-minded physician who's interested in doing this can at least do a safe treatment that has benefits.
Absolutely. Absolutely. I highly encourage you to do that. And kudos for your efforts and doing that. So absolutely. Not everybody's going to do what I do. Not everybody should do what I do. And you have to have certain equipment and certainly the insight, the knowledge, the anatomy, and the other things that keep me up at night. I don't want anybody to have that. You do what you're good at. Do what you love. Do what you're good at. Learn more and expand as you go. But use things that you know work. And I highly, highly encourage you to continue with that journey because you're doing the right things. Expand your mind, expand your knowledge, expand your insight and your skills, and treat those people the way you know how and the things that work.
Well, the other point that we want to talk about is those patients, they have autonomic nervous system disturbance. And there's a diagnostic test for that, which is ANS. I think doing ANS and the theory function test, those patients also, you will see that they have abnormal theory function test. You will see them, they have abnormal pseudomotor testing, part of the complex regional pain syndrome, and does have some sort of neuropathy there. So that's the reason I have Mr. Ken. Are you there, Mr. Ken? Ken, are you there? Okay, he's not there. Ken Beck. Okay, just he's a company who will be able to place. He's a company who can place the system for free in your clinic, no charge up front, and then you can use it. And in this application for neuropathy and pain syndrome, but also you can use it for COVID-19. And I think I shared with you an article that shows that we can now isolate and screen people who are vulnerable to COVID-19 cytokine storm. We find out patients with endothelial dysfunction, they are the one who is having high risk of cytokine storm. I think if we can screen those patients, and most of the patients, they will be obesity, hypertension, diabetes, we can then optimize their health using all these integrative therapies that we're doing, whether it is sex hormone, detox, peptide, microbiome, supplements, name it. And if we are able to improve the endothelial function, we are the right and so this provides us a guide to really manage all kind of chronic disease, including rheumatoid arthritis, neurodegenerative diseases, autoimmune diseases, all your integrative approach. If you want to monitor the efficacy of it, you want to see there's impact on the patient physiology, endothelial function test will be the best test to do. And then you can definitely isolate those people who are high risk of COVID-19 cytokine. That's the trend of medicine. Optimize their health and then check their endothelial function. If they're improved, then you can tell the patient, your endothelial function in the beginning was poor. You are high risk of cytokine. So if you got infected, you may end up into the ICU. That's according to publication, not according to me. So now we're going to do all those screening, making sure we detox you, we give you all the optimization of the health, weight loss program, all that stuff. And then after 2 months or 1 month, we need to check your endothelial function. If it's improved, that's mean what we're doing, it's working. And patients appreciate that when they see the results before and after. I'm not saying you cannot do other biologic markers, oxidative stress markers, and inflammatory markers as well, but this test is the best way to really monitor the efficacy of all chronic disease, including pain conditions. And so I will let Mr. Ken to talk about his system technically, and also how he's going to place it into the focus of the doctors, and what is the detail there, at least 10 minutes for Mr. Ken. Go ahead, Mr. Ken. Are you there?
He's there. He might be muted, Dr. Holasic. You may have to unmute him.
Let's go ahead and mute him. Ken, are you there? I did unmute him. Okay, unmute.
Yeah.
Okay, so let's see if he unmute himself there, and then.
Dr. Lassa?
Yes, can you hear me?
Yes, I can hear you now. It was very difficult. I'm sorry.
Okay, go ahead now.
I did not hear what you were saying because everything kind of blurted out for a while.
Well, I just introduced your system to the people here, and they understand and appreciate the efficacy of it, the importance of it. As this is the stethoscope for integrative doctors. Any doctor who is practicing integrative medicine, he really need to have the system to monitor the efficacy of his treatment. Same like blood pressure. You're giving blood pressure medications, but how do you know it's working? So you use your blood pressure measurements. This is the system that helps to monitor the efficacy of your integrative approach. So go ahead and
Right.
tell us about your
I'm
system.
not sure, Dr. Halassa, how I will implement that because, again, this is somewhat new to me, which is what I wanted to speak with you about, that I haven't had a chance to do in the last week or so since we've been playing phone tag, I should say LinkedIn tag. So, again, I'm here to learn as well because
Okay, so are you
very
Ken?
varied.
Okay, wait a minute. I am looking for another Ken who is the owner of the system, Ken Bick.
No, I'm Ken Andronico.
No, you're the clients. Ken Beck
Right.
is the guy who's manufacturing. I think, I don't know. I'm trying to unmute him, but he's not here, I think.
Oh, okay.
Right. So go ahead. Do you have any questions while I'm trying to connect with Ken? Ken Beck.
I was just going to make one more comment to Dr. Joseph, that remember, because of the surgery, the anatomy is not exactly what it is. So just make sure you feel of course, using the ultrasound is a great idea, but if you decided not to do that, just make sure you palpate the radial artery and you go medial to that area, and you should be safe. Okay.
Okay.
You just want to avoid the artery, basically.
And maybe perhaps inject with like BD insulin syringe, for example. Or, okay.
Yes, but something like that should be sufficient.
And just
you'll be able to reach the scar. You'll be able to go a little bit longer, maybe half an inch. Maybe if you can hit the bone, the radius several times itself, you know, stimulate the tissues there, not just the nerve, not, you know, you're not just going after the nerve, you're going after surrounding tissue as well.
Okay, no, thank you. That's very helpful. Very helpful.
Asking him to talk, and he's not there yet. Can you ask him to
Gotcha.
talk?
You're welcome, man.
Oh, he's on another call. Sorry. Let me see if I can get him.
Yes, please.
Okay, let me see.
All right.
We're having an intermission. Hey, Dr. Angie, I have an interesting point that's been brought up about steroids, the concomitant use of steroid injection with methylene blue or some kind of redox buffering thing. That's been brought up to me several times, and I wonder if you think that has any merit, like to prevent fibrosis or something like that upon.
So I would say that this is what I see when I inject, when we do intravenous area. And we do this a lot. Like we get this really old people who you cannot find the vein on them, and you have to put heating system on their arms so hoping that the vein pops out and you can do IV. But when we are injecting, and normally what we do is our protocol essentially is umbilical cord blood, followed by glutathione, followed by amniotic fluid. Okay, what we see that after people receiving it and after several times, that the vein starts to get healthier, and we can penetrate the vein easier. So we know that the scarring gets less with that. As far as using cortisone, I guess if you use it one time, that is fine. Yeah, I mean, you should be able to get rid of some of the inflammation. So you're saying combine that with methylene blue to avoid the scarring in the vein? Is that what you're saying?
Yeah, it's been, or even when you're talking about like for orthopedic surgery, just basic steroid injections that doctors are doing, is people have asked me about mixing those two things together, and I just wondered about the rationale for that, if there is
Well,
any.
I don't know why you're mixing it. Methylene blue is being used as a replacement for steroids because it does have anti-inflammatory effect. That's according to a publication that's been done treating disc pain, is being done for joints, for SI joints, as a replacement of steroids because it does
That kind of was my understanding as well. So you wouldn't see any rationale to do both. I didn't.
So there is some rationale that is explained by Dr. Schallenberg, who does prolozone, and he recommends that using a tiny bit of steroid. And the idea, the rationale is that you have a lot of inflammation. You want to get rid of some of this inflammation, allowing the regeneration to go smoother and easier. So you use like he uses like half a cc of Kenalog when he's in, again, small amount, or like half a cc of dexamethasone to basically ease some of the inflammation. When the joint is very inflamed, and you are, let's say you're using PRP or umbilical cord blood, you could cause more inflammation. And this way, you get rid of some of the inflammation, and you're allowing the methylene blue to do its job. I think that would be what I would explain to that.
Okay, yeah, I wondered about it. It's been asked several times, so I appreciate it. Mm-hmm.
Well, there is article, and I can share it with you guys. Very interesting, especially we're talking about antifibrotic drugs, because I like the antifibrotic drugs. Methylene blue does have some antifibrotic effect, but also you have losartan, and I saw an article they're using PRP with losartan, oral tablet losartan with PRP injections to minimize the fibrosis and the scarring tissues. I don't know about doing verapamil topical with this case. It may help. Anybody has experience with topical verapamil to reduce the scarring effect after you remove the scar tissue from the carpal tunnel? I don't have any article, but I know that there's an article about using losartan with PRP injection in muscle.
Hello.
Oh, we have Mr. Beck.
Okay, Beck, are you there? Mr. Beck, are you there?
Well, he was.
Yeah. Okay, 1 second. I'm on. Okay. Okay. So he's going to talk about his system.
Hello, can you
Yeah,
hear me?
Yes. We want to learn more about the technical aspect, what it takes for placing your system in the clinics with no upfront charge, and how you're doing the billing. And if the patient does, if the doctor has no billing, in other words, insurance, can you do it in a cash form? So we need that explanation. We have 18 doctors here. They may be interested in placing your system for
great.
$50,000. That would be
Doc,
good.
would I be able to pull up a quick one-page flyer just to kind of highlight the system?
Yeah. Go ahead. I give you the power of the host thing. Where are you? Okay, here we go. Here,
Great, thank you.
I'm the host. You know how to do it, right?
I'm pretty sure.
Okay, now you are the boss.
Okay, I got it. Very good. So I have to share my screen, and hello everyone. I'm really sorry. I didn't realize I would have been more prepared. So I just wanted to show, I have a flyer I'm going to show. Let's see, and I have it right here. Very good. And I just, so Doc, I have to take the screen, right?
Yeah, so go ahead, share the screen. Did you see the green thing?
Trying to find it.
It's the green thing.
Oh, I got it. Yes, I do. Thank you so much.
And then you should screen, okay.
Great. Hello, everyone. So sorry for the confusion. I apologize. Welcome, and thank you, Dr. Alaza. Dr. Joseph, we spoke the other day, and nice to see you again. And Pulse for Pulse, we're the premier autonomic vascular and cardio risk assessment diagnostic company across the US. And this is just a very brief flyer. What we do is offer the equipment at absolutely zero out of pocket. We have state-of-the-art equipment. It goes for $40,000+ at list, and tests, performs 3 tests and up to 5 billing codes. Pseudomotor, autonomic / endothelia function, and ankle brachial index. And we supply not only the equipment, the state-of-the-art equipment, but we supply and pay for a medical technician and an account manager. We also, on an insurance-based model, there's absolutely zero risk on the practice. All the reimbursements go right back to the doctor. It goes to the doctor's office, and by merely testing approximately 5 patients per day, 5 days a week, 20 days a month, there can be as much as $180,000 to $200,000 in new revenue for the practice. That's net revenue. There's also additional revenue for the follow-up visits, complex office visits, 99213 or 99214. We do have a cash model. If someone, if one of your facilities does not accept insurance, we also have a hybrid model. Some offices do part cash and part insurance-based. our billing codes are very, very strong. They've been not only stable, but have been going up, not because the insurance company are nice people, but they finally figured out it's better to be proactive instead of reactive. So, and it's a real honor to work with Dr. Halaza, Dr. Joseph, and some of the other wonderful doctors who know how to explain the technology much better than we do. I'm not a medical person, but I just wanted to kind of go through this early diagnosis. On the left side of the screen, diabetes, hypertension, cardio-autonomic neuropathy, and so on. We do check for medical necessity. I can also show that questionnaire if you would like, but we do the testing. We don't need office help, office staff. We do all the heavy lifting. We realize that the practices are very busy, trying to just do what they do on a daily basis. So we take care of everything. We also supply a wonderful condensed report with our proprietary algorithm. It's a three-page report with a summary page. The physicians love the reports. Once again, approved by major carriers, $155 to $170 net revenue per preventative test protocol. And we can retest. Most insurance companies allow up to 4 times per year, including, well, the first test would be the baseline. So it would be the baseline plus 3 additional tests. And we would be very honored to book a private Zoom call with you to get more information. We love preventative care and everything that the Dr. Halaza, Dr. Joseph speak about. So we thank you for welcoming us here today. And Dr. Halaza, do you think it'd be best if I put my email or phone number or
Yeah, go ahead. Do whatever it takes for you to start moving your system, because I need all my membership and fellowships to have this system. We need data that helps us to guide the efficacy of all the integrative therapies that they're doing. Because I see a lot of doctors, they're doing 6 hormone peptides. Okay, so how you know you really have impact on the body? What is the diagnostic parameters that you're using? Another thing is for COVID-19, this is the best way of screening people who are high risk. And I think this saves life, because the idea of contact tracing and screening, it's good to just for epidemiology, but it's not really anything to do with saving lives. Saving lives with I think now it's 10 million cases. That's mean multiplied with 10, according to the CDC. We have 100 million cases in the United States. 1/3 of the United States is infected. So contact tracing really will not save lives. The only way you save lives is to determine the people who are high risk of developing cytokine storm and optimize their health. And that's not me saying that, even Dr. Fauci is saying that. And he's saying, well, vitamin C and D and all that stuff. But there's more than vitamin C and D to optimize their health. You know, it takes weight loss, all the program that helps to improve the endothelial function test, all the protocols that you're doing as integrative therapies will definitely help to improve the endothelial function test finally. It gives you a guideline for your treatments.
Yeah. Dr. Halaza, I'm trying to look on this paper and I don't see anything that says endothelial test.
Oh, they do. It's a system that has ANS, endothelial function test.
Well, that's an ANS, that's not endothelial.
ANS, they do have endothelial. Autonomic function, I think they're just missing it. They have.
Yeah, I'm so sorry to interrupt. It's part of the ankle brachial test, the ABI test.
Okay.
But you have to write it down.
Yes.
Okay, this is, I actually am very familiar with the test, and I have a couple specific questions, if I may,
Certainly.
for Ben. This has, may be under other names in different parts of the country. This does something that is called IntelliWave. Does that ring a bell?
In Telewave, they don't do endothelial function test. They do only ANS.
Well, I'm
Yes.
looking and I don't see any ANS. I mean endothelial. So where is it on this one? Because I still don't. I'm looking for it.
Yeah, you need to write down endothelial function test. I think it's part of the
How
API.
is that done? Is that through a
This-
system by like Vendy's? Is it a system like Vendy's or no?
It is system like Vendy's. I used to have one with this system that's combined. You do it has a piece of the finger, which is for the endothelial function test, and then they have all the electrodes for the heart, for HRV. But this system is a combination. So yes, it does have the endothelial function test, and whoever wrote this, he needs to put it down as
Yes.
a endothelial function test.
Yeah,
Yes,
because that's where I'm getting confused.
Yeah,
Yes,
so
and I'm sorry. Pardon me for interrupting. I'm so sorry. This is a very basic flyer, and I just would like to compliment everyone on the call tonight. Dr. Halaza, and it's just so far advanced. Most of the doctors, we get into more detail on a private Zoom meeting, but these flyers are very, very basic. Just kind of a drop-off flyer, but it absolutely does have the endothelial test as coupled with the ABI.
I did many of those things. They used to be, it's very primitive. The first one who create the system, it's a company that does only autonomic nervous system. And it's very primitive. So we have to do all the logarithm ourselves by adding and there's a calculation we have to do it. But then it starts to be advancing, and many companies there start putting together the ANS with the endothelial function test with pseudomotor, which is very important for neuropathy. So if you have neuropathy business, this is a good way, very rapid testing that gives you the idea about your neuropathy. And then you do the topical cream, and Dr. Mike Beamer will develop for you the topical cream that contains nitroglycerin for neuropathy and many other things. We call it nitro base. And you can manage neuropathy very effectively with the formulations of Dr. Mike Beamer. And then after 3 months, you can test it and you can bill it to the insurance. I think every 6 months for sure. I don't know about every 3 months. I know for the insurance every 6 months. Is that the case, Dr. Ken, Mr. Ken?
Yes, this is absolutely approved every 3 months with medical necessity. There
3
is
months
another-
or 6 months? Because they don't allow us for 3 months before. I don't know if they change it.
Yeah, no, definitely 3 months. First is a baseline. We're very proud. We have to say that we have a healthcare attorney on staff. He ran major hospitals in the Northeast, and everything we do is absolutely according to the way it's supposed to be done. We absolutely don't cut any corners. And we would be, the doctor who is speaking, we would be very honored to get our CMO on a call with you, and he could certainly lay out the endothelial and ABI and all the test protocols and whatnot. He really enjoyed speaking with Dr. Halaza, and Dr. Halaza, remember he mentioned endothelial function is the most important, right?
Yes, yes. And it does give the doctor the idea about his integrative therapy works or not, including peptides, 6-hormone, whatever he's doing. He wants to know whether there is impact on optimizing the health endothelial function test, because endothelial function test is a reflection of your redox status. So if you enhance the antioxidant capacity, then you improve your endothelial function 10, and your endothelium that lines the blood vessels, because they're very sensitive to the antioxidant capacity, the balance of the antioxidants with the free radicals. So it gives us an indication. It's same like telomeres also is another way. Shortening the telomeres, yes, that's one. There's a lot of also oxidative stress markers, but this is more easy going, doing it fast, and it gives you the results. And it really gives you that physiological response to the treatments.
May I ask one more question?
Certainly.
The billing. Tell me about the billing.
Right. So we have two options, and we've been. My wife and I have been in the medical space for many decades, and we can't tell you with different program systems, and we've seen the good, bad, and the ugly. We have an expert billing staff, and all they do, and I'm very happy to show you those codes quickly, but we either can do the billing for you, or we always provide, at the very least, a billing liaison. And I'm going to pull that one slide up with your blessing. It just take me maybe 1 second. Here it is. And let's Zoom share. Very good. Whoops. Here it is. So this particular slide. I'm sorry. Can you still hear me?
Yes, we can hear you. Yes.
DHA certainly now you probably can't. So wait 1 second. Second there, I don't know how to do it.
Don't worry, man. You're gonna get better at it
This is a
because this Zoom is here to stay.
This is a pre-recorded presentation, so I apologize. But these are the 5 billing codes, Doctor. I don't know if I've answered your question, but we built up to 5 codes. Certainly it varies state to state. These are the complex billing codes for the follow-up visit 99213, 99214. And we had a huge blessing, which really helps with social distancing during the pandemic, but the follow-up visits can be done via telemedicine.
I'm sorry, but the codes are not on the screen, just FYI.
Oh, sorry. Let me just, let's see, how about now?
Yes, we can see it now.
Oh, great. Thank you for that. So sorry. I guess I didn't push the right button. We do the follow-up visits via telemedicine. We also, and again, we're not doctors on this side of the call, so we might have to lean on Dr. Halaza, but this is our proprietary algorithm, and it's red, yellow, and green light, of course. And of course, red being abnormal and yellow borderline, green normal. We give this report, it's a 3-page report plus a summary page is available immediately when the test is done. We hand it to the doctor. The test takes 15 to 20 minutes max. And then you get the report. It also has the acceptable ranges right on the report. And our physicians absolutely love this report because it's just right to the point and really uncovers an awful lot of things.
And what is that reimbursement for the doctor? How much the doctors will get, how much your company will get, and how you spread that, how you do that?
Right, so let me see if I can't get to, here's the basic, I'm sorry, I'm trying to shut this recording off when I shut this, but this is the finances and revenue. So the reason we generally doing 5 tests per day is no issue whatsoever. Depending obviously how many patients are seen, but doing 5 tests per day, which would be 20 days in a month, in 1,200 per year. That's the estimated revenue. Certainly it can go up a little bit or down a little bit depending upon the demographics, the type of provider, and the area of the country you're in. And of course the payer mix. So what we do, we get a form and we ask a simple form to be filled out, which is right here. And sorry to do this. We have this simple form and we fill it takes about 5 minutes to fill this out. And then we'll give you your exact pro forma based on your practice of what you can expect to make financial gain. And this is really the only information we need. So it's safe to say that anywhere up to $200,000 per provider seeing 5 patients per day.
And I will do all the patients to get their basic data, and then I will start treating them with all the integrative approach that we are doing. And then after 3 months or 6 months, I'll test them again, and I will see whether my treatment works. My peptides work, 6-hormone works, exosome works as a combination effect on the redox status and the cytokine profiles and the endothelial function, of course. I think this is a good thing to, and also it's very critical for this time to isolate patients who are at risk of COVID-19 and optimize their health. But this is a screening test that you can do. In addition to Dr. Cole program, which is testing the COVID-19, I think with Joe Biden is talking about rapid testing, and there's a big funding for rapid testing. So every clinic needs to do rapid testing for the COVID-19. It's going to be mandatory, I think, with Joe Biden thing, if he got elected, because they like testing. But this helps to clear the clinics from, from being infected with COVID-19 and closing your clinic. I think Dr. Cole has that program. If you want to go ahead with 5 minutes with your program, that's fine.
Okay. It is important that people realize that, yeah, they're going to put a huge emphasis on testing, but who's going to do it? So everybody that I'm talking to, think about their primary carers. None of them are doing testing. None of them. Why? Because they're not getting paid to do it. And they can't afford to expose their staff, pay for the tests. Like I'm talking to AJ, and some of these tests are up to $40, and paying for it, you're going to be the best doctor that ever went out of business, making, Quest and LabCorp rich. It's crazy. So the differentiation is CLIA versus CLIA waived. CLIA waived are point of care tests. Up to this point, there had not been testing, antibody or antigen testing, that was rapid and CLIA waived, along with the EUA emergency use authorization. Just because it's EUA does not mean you can bill Medicare or Medicaid. You cannot read the results. So there's a program that I'm putting together that I'm finishing up all the protocol, just an outline, guidelines, and micro exposure. And that's the thing that you guys are going to love. It's a micro exposure for the clinics. So you, your staff, your patients will not have to worry about people coming that are infected that will infect everybody else. And that's really one of the key points of it, in addition to all the codes. I'm going to give everybody all the codes. Everything that I've vetted, of course, you can feel free to check out based on all the resources that I give you, which are going to be the CDC resources, the AMA, all the coding information, re-verify every bit of it that you want and that you would like. The tests that I was able to access, once I told them I wanted to put this program together, and it's going to be under the name freedomfighters.us. And why? Well, it's doctors fighting for your health. That's the motto. And you guys are going to love this part. The part of testing is going to be done by the doctor division, which is the Health's Angels. I love that name. So the health angels are going to be doing the, getting the test, knowing how to do it. And for each test, you can actually optimize it with the telemed visit beforehand, after you get the phone call, to literally qualify them, whether it's new or existing patient. Don't have them come into your office. Second, when they do come in for the test, they stay in the car. Oh yeah, they stay in the car. You bring out the tray with the PPE for them and you, of course, and you put on the sonic tray right on their window. You verify the ID. Of course, there's other steps involved that you have everything done from the car, calling into your office. But they put their finger out the window. You get the little finger prick or the swab, whichever it is. Boom, put it on the kit. That's it. 30 seconds. Micro exposure. The next day, you give them the results, even though it's a rapid test. Or you really want to do 50 of these and have to go out every 10, 15 minutes and give the results? No, you do it on a telemed visit the very next day. Minimal would be $300 on every bit of the codes, because there's, how many guys did you know that there's actually a code for your PPE? How many of you did you know that you have a code for the patient to receive PPE, even if you give them the shield and gloves? Did you know that? No. Did you know there's a code to transfer the blood? Did you know there's a code to actually do antigen versus antibody? And at the same time, you should be doing the flu test, because the flu is going to be horrible this year. There's an A and B flu test that's going to be great. And that's one that's going to be available for like $15. And I'm getting them available to everybody. So the manufacturer said, we can't give them the program. I said, why? We need to get testing. The sooner you get tested in every office, every clinic, every facility, we can identify the ones that are sick and start to treat them. They said, well, you can do it, but you're going to have to be the manufacturing distributor. I said, I can't warehouse them. They said, we'll drop ship to all the people. Have it prepaid and drop ship. I said, okay, I will volunteer to do that, but I wanted to have my program. Even if you want to drive through, I already have the actual drive-through protocol that I was going to do on an IRB, and you can have it. Why am I doing this? Dr. AJ knows, Dr. Schwani knows, and Dr. Alasa knows, because I have a 9 and a 10-year-old, and I want them to have a life that's better than this, so it doesn't last their entire lifetime, where they'll live their entire life with a mask on. That's why I'm doing it, because I'm trying to make a difference, and we know we can. In every doctor's office, ER, every facility that tests, surgery centers. So think about that for a second. You can go out and offer your services. Now, there's one caveat. There's one thing that I am getting all of my doctors that are getting on board with me, with the freedom fighters, fighting for your patient's health. There's one caveat. You must go out to your neighborhood, out in your community. Go to the small businesses and test them. All the ones that have insurance, they will pay for it. These people will love you for that, keeping their staff safe, their families safe, their patrons, whether they're a restaurant or a place that's just goes out and fixes the plumbing. I mean, these are the businesses, the small businesses that keep our economy going and keep our country alive and give us our way of life. So go to the small businesses and test them regularly, and they will get paid for by the insurances, and they will love you for it, for saving them business, because who can afford to be out of business for 2 to 3 months? So it's all going to be in writing. It's all going to have the recommendations, resources, and different type of information that is available, but I'm going to give it away. I really feel strongly about this, very strongly. I bought the damn website, guys. I bought freedomfighters.us. I am talking to Moldova, the country. Why? Because they're the ones that own the extension MD, because any 2 letters are actually country codes on the websites, the top level domains. So MD happens to be Moldova. And I happen to be in contact with Moldova, working out how I can get freedomfighters.md. I've already acquired 941, which is my area code, freedom for the phone number. So I'm in on this for the long haul, and I'm going to try to do whatever I can to help. So you guys need to know that.
Thank you very much, Dr. Cole. I think everybody here want to be a free fighter with you. That's a good.
Oh,
That's a good,
that's
a good slogan for this new year, 2021.
I
Dr.
think so.
Cole, we're doing a presentation tomorrow for the Florida Academy of Pain Medicine, and we'll
Yes.
mention your group there for you.
Right.
Thank
And
you very
so-
much. If you need 5 minutes of my time, just let me know. I
Right.
will make it shorter. Oh, the test. The antibody tests currently that also differentiate between COVID and anything else are coming. I have those, and those antigen tests, IgA, IgG, those are just $12. The ones that have the flu, A and B are like $15. That's it. So I looked, and they have a lot, man, they're a lot more expensive than that in most places. And I'm in the process of getting the antigen tests. I'm getting a resourcing because I thought that $30 was way too expensive. So I'm looking at a different source. So I'm trying to procure those at a much, much more affordable rate. So I'm working on that, but I will make sure that everybody has everything that I have, and it's at your disposal. I am here fighting for our country and fighting for us to get our country back, and that way we can live our American way of life, go back to our churches, our sports games, our cookouts, our families, and without losing our family members. Enough is enough. It's enough to have the government and big pharma running the whole damn show and doing a cluster puppy out of it. Enough. Put the doctors back in the game. And right now they're on the sidelines. That's enough. We need to get back in the game, start practicing medicine. And by the way, this is the second part of it, which I didn't say, is the treatments, which we know how to do better than any of these fools. Because the answer is not necessarily going to be waiting for a vaccine that may or may not work. It may or may not have side effects. Other types, we already know the treatments. So after they are under your peruse, after they trust you and they know you're working to fight for their health, then you can introduce them to your treatments, because, by the way, when they're in their car, you've given them all of your brochures, the information, and your pamphlet with a sushi list. I love this idea. The sushi list says, hey, by the way, I do this and this and this and this. If you see something that you, your family, your friends might be interested in, put a little check mark on it. Now, I'll call you later about it, but let's get you taken care of for now. So you get an opportunity to actually build your practice. So it's a beautiful way to do that. It helps everybody involved, and it's going to make a huge difference.
So if you're looking for the treatment, we have here a pharmacist. I think they're very successful putting together oral methylene blue photodynamic therapy with supplements.
Sure.
You want to talk about it, Dr. Mike Beamer, about your experience with your doctors using your kit?
What's
Dr.
in the
Mike.
kit?
Yeah, a lot of people have done that. Well, we presented on that several times on this forum. But yeah, we have an oral photodynamic therapy kit that utilizes methylene blue mouthwash, basically, that performs photodynamic therapy and eradicates a wide number of oral pathogens, microbes, including viruses, and of course, including all or most of the enveloped RNA viruses, which includes COVID. So this technique is used to sterilize or to remove viruses from plasma while leaving the immune factors and proteins and such intact. So it's the same basic model, and we're just using methylene blue and 660 red light and a very bright one in the oral cavity. I actually leave it sitting on my desk where I use it. But it's a very interesting little device. It looks like this. You put it in your mouth and it's very bright. You can see quite bright. And it's a little battery operated. It has a timer. These are $100, not very expensive. And comes with a charger and the whole 9 yards. But yeah, that is something that's been effective. I know some of the people on the forum have used it, prescribed it, and we're waiting to do more testing on it, but it seems to work well from all anecdotal reports. But yeah, just using this little device and red 660 in the mouth with methylene blue, and you will eradicate a lot of pathogens. And of course, we know that the COVID virus spreads by moving down the respiratory tract to the respiratory tree or to what other ACE receptors that it can access via saliva, mucus, and things that are either being swallowed or ingested further into the body, breathed into the body. So if we can prevent that step, we're shorting out the rate limiting step, or kind of the if we catch it at the mouth and the nose, then we're better off than letting it get further. So anyway,
what all is included with the kit? Because somebody asked me that before, and I said,
That's a good question. You know, we can do it different ways, Dr. Cole. Certainly you get the light and you get the mouthwash. That would be the smallest way to do it. And then we have other options if you want. If there's a person that you want to have on oral methylene blue, of course, we have capsules for that. If you want somebody to we have the lozenges. It's like a supplement that you can use with the zinc and vitamin D and quercetin. And it's sort of an oral lozenge that you can pop in your mouth, maybe underneath your mask. That way, if you breathe in something, if you're going to the grocery store, you have a lozenge in your mouth, you have your saliva is full of zinc and curcumin and quercetin. So if you happen to breathe in a virus before you eradicate it that night, theoretically, then, you know, this lozenge can be helpful. And those have been most popular with people like UPS drivers or people who are really, you know, exposed to a lot of people by their job, and they really don't have any say in it. And so those have been less popular because you know, there's other options there. But you know, that's something that you can add to the kit. And you know, I think from there, we in the past we'd offered some other medications that have kind of come and gone as recommendations. So we've omitted those now. You can still get hydroxychloroquine and that kind of thing. So much.
One last question. I'm so sorry. This is a good question, though. Somebody asked me, would it be beneficial for chronic halitosis?
Yes, for sure it is. Yeah,
and that's what I thought, but I wasn't sure. So,
as a matter of fact, the light device, that's what it's FDA approved for, right? Teeth whitening, they say, and bad breath, because the red light has some antimicrobial effect. But obviously, when you combine it with photosensitizer and yes, absolutely. Same thing for dental reasons. You know, that's why Dr. Halas and I developed this thing. Really wasn't for COVID. It was because at one of Dr. AJ's conferences, in fact, a couple, 3 years ago, a dentist was there and he was talking about implants and infections and the implants that were, not accessible from the outside of the body, obviously, and they, were resistant to microbes and things of this nature. So he talked about phototherapy and all this, and then kind of a period of time went by and we didn't do anything with it, and COVID came and we realized that it was kind of applicable to this. So that's really where the idea came from.
Thank you very much.
And one thing you can also do, like you have the key though is the rapid testing, guys, because up until now, how do you know really who should get this? But my feeling is if you have somebody that tests positive on a rapid test and they haven't gotten sick yet, and you caught them on day 2 or something like that of this, seems like a good time to have one of those kits overnighted. And you can do that for way under $200. I think they're $150 to $60. And, well, maybe if you overnighted it, you get it somewhere for $200, which isn't horrific amount of money for something that will help. So anyway, yeah, that's what we have. It's very interesting.
And don't forget,
we have a guest
recommended for their. I'm sorry, you should recommend it for their contacts. Everybody that they've been contacted with, anybody that comes up positive, you definitely have to recommend this for everybody that they've contacted. So
it's a good idea. Yeah,
especially for healthcare providers. Yes,
tested and treated.
Doctors, nurses, those are the ones who are our clients mainly. And they can feel more peace mind to go back at home and without, infecting their family. So yes, healthcare providers are the number one who needs to use this testing. And that's why we have Dr. Harati from Australia. I think he will be interested to replicate what we're doing here in the United States and Australia. And we have a lot of things that we can share. And
yeah, I'm sure that can be done. Australia has a robust compounding pharmacy industry, I'm aware. So good for them. Good for them. Yeah, I'm sure that's something that they could do there.
Are you there, Dr. Horatio?
Yes, I'm here. Yeah.
Hi, is it Dr. Nee?
Dr. Horachu from Australia.
Yeah, thank you for joining us tonight.
Work with you, helping you to replicate what we're doing here in United States. And then I have your team of doctors who are interested in our protocols. So hopefully we can, network with doctors there, adapting our protocols that we're doing here in managing chronic disease. And there will be centers in Australia for chronic disease management centers and fellowship program. But we need to have a compounding pharmacy to supply them with the formulations that is customized, that lines up with our education platform. That's why we invited you here to see if this interests you. Then we can go through all the process. And then we have Dr. Mike Beamer technically will be helping you from A to Z to set you up with all the formulation that we're doing. We have endless of formulation.
We would be happy to share that information with your pharmacy, for nothing. Yeah, just as a courtesy.
So we definitely need to look into it, and interested anyway. Yeah, thank you.
Sure, absolutely. Yeah.
Okay, Doctor, we have Dr. Farshan. Do you want to say anything? Is he left? Dr. Farshan? I think he left. Okay. So anybody has any questions? Everybody's happy here?
Yeah.
Okay. Any questions?
Very happy.
Tired.
That's it, everybody. It's time for bed, right?
Yes.
So you want to conclude the meeting, and we can see you Thursday, 7:30 p.m. every week. I think I'm going to present next week central pain. I have a very nice lecture about central pain management.
The brain twister.
Yeah, but you need to have a lot of copies because it's hardcore, but it's animated, all animation, so you can see the whole central pain, neuroplastic change in the brain, drug addiction.
PTSD.
Yeah, complex regional pain syndrome, all together, put together in a very nice animation. So we're going to do that in the next week. But I need you all to be linked to LinkedIn. I need you all to connect with me on LinkedIn. Just connect with me so I can invite you to the coming conferences, and you can see, there's lots of doctors interested. But LinkedIn is a very good way of communications and putting together in events, inviting people. So please link with me through LinkedIn. And if you have any suggestions, any business proposal, any ideas, any protocols you want to share it with our team, we can work together and we can help you to promote it through our platform.
Right. Dr. Beamer, was it you that said there was a American Academy of Pain Physician meeting tomorrow?
Tomorrow, yeah.
Yeah. What time does that occur?
It's Florida Academy of Pain Medicine. It's tomorrow morning, early.
Like what? I'm sorry, you.
It's actually Friday.
What time?
I will send you a link. It's Friday and Saturday. It's a closed meeting. I think they charged admission or something like that.
Right. Well,
but yeah, I can send you a link.
Right. I'm sure that the doctors would be very interested in ways that they could help to keep their staff, their patients safe at a minimum, let alone all of the community, their small businesses.
We're speaking on this subject tomorrow. So yes, I will bring up your program and get you included in that. And I probably can't get you time because it was pre-recorded, a lot of it, and it's just Q&A tomorrow. But yeah, I realize what you have here is of great interest to people, and not only that, it's a great.
It'll take time to get the word out. It will, but that's okay. We'll get the word out.
But I can get you all the contacts. Yeah.
Yeah, I appreciate it very much, and I'm on a quest. I'm on a mission. So, thank you very much. Good evening, everybody.
Good night, everybody. And I will close out. Thanks so much for attending, and welcome from Australia. We appreciate you all attending. Australia has the most for tonight.
As they say, good night, mate.
Thanks,
guys. Good night, everybody.
Thank you.
Take care.
All right.
Thank you.